Basics of Medical Biochemistry. First edition, 2024. Chapter 21. Vitamins, Part 1 of 4. By Professor Dr. Muhammad Jawad. MBBS, Tao, M. Philosophy, Ph.D., Dip M.E. Head of the Biochemistry Department-Fazaia Ruth Pfau Medical College, Air University-PAF Base Faisal-Karachi-Pakistan. Ex-Professor of Biochemistry, Qassim University Kingdom of Saudi Arabia. Ex-Professor, Head of the Biochemistry Department and Vice Principal. Liaquat College of Medicine and Dentistry and Fatima Jinnah Dental College, Karachi, Pakistan. Chapter 21. Vitamins. 21.1 Introduction. Vitamins are several chemically unrelated families of organic substances that cannot be synthesized by humans and are essential in small amounts for normal metabolism. A few are conditionally essential, meaning that they are essential under certain conditions such as vitamin D, which is essential in the absence of adequate sun exposure. Vitamins are the constituents of diet, in little amounts but play vital roles in maintaining normal metabolic activities. They are needed for good vision, healthy skin, blood cell formation, healing, blood coagulation, healthy bones and teeth. As humans cannot synthesize sufficient quantities of vitamins, thus, vitamins must come from other sources, i.e., through the diet and/or in pill form as a nutritional supplement. All vitamins are complex organic substances. They have low molecular masses. Essential vitamins for one species may not be essential for other species. Some vitamins are synthesized in the body. Vitamins are not destroyed during the digestive mechanism and are absorbed as such. Daily requirements for vitamins are increased during growth, pregnancy, and lactation. Unlike carbohydrates, proteins, and fats, vitamins do not supply energy. However, some vitamins do function as coenzymes in the release of energy from carbohydrates, proteins, and fats. A deficiency of a vitamin in the diet leads to a health problem. The general symptoms of any vitamin deficiency include frequent illness, slow healing of wounds, tiredness, and growth retardation.
21.2 Classification of vitamins. Vitamins are divided into two groups: fat-soluble, vitamins A, D, E and K, and water-soluble, vitamin B complex and vitamin C. Vitamin B complex is further categorized into energy-yielding, blood-forming, and miscellaneous. Fat-soluble vitamins are obtained from food like oily fish and cheese. Water-soluble vitamins are largely obtained from leafy vegetables and fruits.
Figure 21.1 Classification of vitamins. Fat-soluble vitamins have long nonpolar hydrocarbon chains or rings. Fat-soluble vitamins usually accumulate in tissues and are not leaked out quickly. Unlike water-soluble vitamins, an excess of a fat-soluble vitamin can be just as harmful as a deficiency. 21.3 Vitamin A. Vitamin A is a fat-soluble vitamin. The other names of vitamin A are retinol, retinol, retinoic acid, anti-xerophthalmic factor and anti-infective factor. Its precursors are carotenoids such as beta-carotene. Different forms of vitamin A, these are preformed and provitamin A. 1 preformed, 3 preformed compounds that are metabolically active and found in animal products. These are retinol, alcohol form. Retinol or retinaldehyde, aldehyde form. Retinoic acid, acid form. 2 provitamin, carotenoids, beta-carotene, and cryptoxanthin can yield retinoids when metabolized in the body. These are from plant sources. Beta-carotene is derived from green leafy vegetables and 2 g of beta-carotene is equivalent to 1 g of retinol. Beneficial effects of beta-carotene include: acts as an antioxidant. Increased consumption of beta-carotene is associated with decreased incidence of heart attacks, skin and lung cancers. High doses of carotene for long periods are not toxic. Figure 21.2 Different forms of vitamin A** shows the site of cleavage of carotene. Sources of vitamin A. Animal sources are liver, milk, egg yolk, etc. Plant sources are carrots, green leafy vegetables and orange-colored fruits such as mango and apricots. Absorption, transport, storage, and excretion of vitamin A, retinyl esters, found in many animal tissues are regarded as the dietary source of vitamin A. After ingestion, they are hydrolyzed by pancreatic enzymes to retinol and fatty acids. Similarly, beta-carotene present in plant-derived sources of vitamin A is cleaved into two molecules of retinol by beta-carotene 15,15 dioxygenase with the help of cofactors iron and bile salts. In the intestinal cells, the esterification of retinol, obtained either from retinyl esters or beta-carotene, takes place to reproduce retinyl esters. Retinyl esters are secreted from enterocytes as a part of chylomicrons into the lymphatic system. Chylomicrons metabolized to give chylomicron remnants having retinyl esters. These retinyl esters present in chylomicron remnants are picked and stored, when the concentration exceeds significantly, by the liver. The liver stores 90% of vitamin A in the body, and this reserve is adequate for several months. At the time of need, retinol is released from the liver and transported via the blood to target organs by tightly bound to retinol-binding protein, RBP, in association with transthyretin. In the target tissues, retinol is oxidized to retinoic acid, which binds to nuclear receptors and activates the respective genes. A small amount of retinol is excreted in the urine. Kidney disease and aging increase the risk of toxicity because excretion is impaired. Recommended dietary allowance, RDA, an adequate intake daily, aid**, of vitamin A. Infants and children, 400-500 g. Adult males, 600 to 900 g. Adults females, 600 to 700 g. Pregnancy, 750 to 800 g. Lactation, 1200 to 1300 g. Functions of vitamin A. 1. Role of vitamin A in vision. Vitamin A is a component of the visual pigment rhodopsin. It is formed by the binding of the retinol to the protein opsin. Retinol turns visual light into nerve signals in the retina of the eye. Retinoic acid is required for the structural components of the eye. Cones in the retina are responsible for vision under bright lights. They translate objects to color vision. Rods in the retina are responsible for vision in dim lights. They translate objects to black and white vision. The visual cycle is the process where light impacting the photosensitive cells of the retina is converted into electrical polarization that generates nerve stimulation. Formation of photorhodopsin. Retinaldehyde is a prosthetic group of light-sensitive opsin protein. In the retina, all trans-retinol is isomerized to 11-cis-retinol, which is oxidized to 11-cis-retinaldehyde. This reacts with opsin, lysine residue, to form the hollow protein called rhodopsin. Absorption of light causes conformation changes in opsin to produce photorhodopsin. Figure 21.3 Formation of photorhodopsin in the visual cycle. Formation of all trans-retinaldehyde and opsin from photorhodopsin. The photorhodopsin passed through a series of isomerization reactions involving cGMP and GTP. The final step is hydrolysis to release all trans-retinaldehyde and opsin. Figure 21.4 Formation of all trans-retinaldehyde and opsin from photorhodopsin. 2. Growth and development. Vitamin A promotes bone and teeth development. It helps the normal growth and development of an individual. Individuals deprived of vitamin A show slower growth of bones, which may lead to CNS damage and paralysis. Defects in the normal structure and texture of tooth enamel may result from its deficiency. 3. Reproduction. Retinol and retinol are crucial for normal reproduction. In the male, it facilitates the process of spermatogenesis. In females, it prevents fetal resorption. For maintenance of epithelial cells, vitamin A is essential for the normal differentiation of epithelial tissues and mucus secretion. Sufficient amounts are required for the stability and integrity of cellular and subcellular membranes. 5. Skin and mucous membrane. Vitamin A is necessary to keep skin and mucous membranes healthy, also maintain proper hair growth. 6. Metabolic role. Vitamin A is involved in the formation of mucopolysaccharides, glucocorticoids, and proteins. It is also involved in the metabolism of nucleic acids and the normal activity of the electron transport chain in mitochondria. Deficiency of vitamin A. 1. Visual impairment. The early sign is a loss of sensitivity to green light. Prolonged deficiency causes impairment to adapt to dim light, and more prolonged deficiency leads to night blindness. Further severe deficiency leads to squamous metaplasia, in which columnar epithelia are transformed into heavily keratinized squamous epithelia. The conjunctiva loses mucus-secreting cells, and the glycoprotein content of the tears is reduced to produce xerophthalmia, dry eyes. Bacterial or chlamydial infection may result in perforation of the cornea and blindness. 2. Effect on epithelium. Transformation of respiratory epithelium leads to loss of protective airway function, antibacterial properties, thus becoming prone to bronchitis. 3. Effect on renal epithelium. Conversion of the urinary tract epithelium leads to a higher frequency of urinary stone formation, urolithiasis. 4. Immunosuppression. Impairment of reproductive function, both in men and women. 5. Worldwide deficiency of vitamin A. It causes 3 to 10 million children become xerophthalmic every year. 250,000 to 500,000 go to blindness. 1 million die from infections. Toxicity, hypervitaminosis, of vitamin A. Vitamin A is not readily excreted. Hypervitaminosis A in humans occurs as a result of self-medication and overprescription. The main symptoms are skeletal malformations and spontaneous fractures, birth defects and miscarriage, decalcification, joint pain and fragility, dry itchy skin, hair loss, liver damage. Overconsumption of beta-carotene from food sources may cause the skin to turn yellow but is not harmful. 21.4 Vitamin D. It is a fat-soluble vitamin also known as cholecalciferol, ergocalciferol and anti-rickety factor. The precursors of vitamin D are sterols. About 10 compounds of vitamin D are known as vitamin D1 to D10. Only 2 of them, vitamin D2 and D3, have anti-rickets properties. Vitamin D2, ergocalciferol, is plant-originated, while vitamin D3, cholecalciferol, is animal-originated. Sources of vitamin D. It is not well distributed in nature. A few rich sources are liver, viscera of fishes, salmon, sardines, herring and mackerel, egg, butter, fortified milk, liver oil, cod liver oil, etc. Activation and formation of vitamin D. Vitamin D is produced when sunlight or ultraviolet light falls on the skin. 1. Formation of vitamin D3. Cholecalciferol. Vitamin D3 is produced from 7-dehydrocholesterol, provitamin D3. The 7-dehydrocholesterol is found in abundant quantities in the epidermis, probably as a side reaction product from the cholesterol-forming system. It is regarded as an immediate precursor of cholesterol. 7-dehydrocholesterol reductase is the terminal enzyme of cholesterol synthesis, which converts 7-dehydrocholesterol to cholesterol. The deficiency of this enzyme results in the accumulation of the substrate 7-dehydrocholesterol, which leads to increased production of vitamin D3 by isomerization upon exposure to ultraviolet B, UVB. 2. Formation of vitamin D2, ergocalciferol. Vitamin D2 is produced from ergosterol, provitamin D2, upon exposure to ultraviolet B in plants. The only change that takes place during the conversion of provitamins D to respective vitamins D2 and D3 is the opening of ring B of the steroid nucleus in between carbon numbers 9 and 10. Further activation of vitamin D, D2 and D3, takes place in the mitochondria and microsomes of liver cells by the enzyme 25-hydroxylase to produce 25-hydroxyvitamin D. The final activation of 25-hydroxyvitamin D takes place in mitochondria of renal cells present in proximal convoluted tubules of the kidney, by the enzyme 1-alpha-hydroxylase to produce 1,25-dihydroxyvitamin D. This enzyme needs Mg2+, NADP plus H+, cytochrome P450 and O2. The importance of sunlight exposure is quite significant in the formation and activation of vitamin D. However, some people, such as the elderly who are housebound or those that live in northern climates, particularly females with an extra covering on religious ground, have very little exposure to sunlight. These peoples are at risk of suffering from vitamin D deficiency. The condition may become more serious when they have a limited intake of vitamin D fortified milk. For these people, additional care must be taken to ensure they consume enough high sources such as cheese, eggs, fortified breakfast cereals and margarine. Figure 21.5 Formation and activation of vitamin D. Factors affecting formation and activation of vitamin D. The final active form of vitamin D is 1,25-dihydroxy-vitamin D or 1,25-dihydroxycholecalciferol, calcitriol, which is produced in the kidney, by the enzyme 1-alpha-hydroxylase. This enzyme is stimulated by hypocalcemia and hypophosphatemia as well as by many hormones like a parathyroid hormone, PTH, growth hormone, prolactin, estrogen, progesterone and human chorionic somatomamotropin. Whereas, high levels of calcium, phosphate, and 1,25-dihydroxy-vitamin D inhibit this enzyme by the feedback mechanism. Absorption, transport, storage, and excretion of vitamin D. About 50% of dietary vitamin D is absorbed by the enterocytes with the help of bile salts. The absorbed vitamin D first appears in lymph and is then transported to the blood circulation as a component of chylomicrons. Part of this vitamin D is taken up by a variety of tissues, example fat and muscle, before the chylomicron remnants and its vitamin D are finally picked by hepatocytes. Adipose tissue is the major site of vitamin D storage. The inactivation of vitamin D mainly takes place in the liver by the hepatic microsomal drug metabolizing system. The primary excretory route of vitamin D is via the bile into the feces. Urinary excretion appears small in magnitude and no excretion products have yet been known. Recommended dietary allowance, RDA, of vitamin D. Infants and children, 400 to 500 IU, 10 to 12.5 g. Adults, 400 to 800 IU, 10 to 20 g. Pregnant and lactating women, 400 IU, 10 g. Note, IU, International Unit, of vitamin D equals 0.025 g. Functions of vitamin D. 1. Calcium absorption from the gut. Vitamin D promotes the absorption of calcium from the gut by increasing the synthesis of calcium-binding protein in the intestinal mucosa. 2. Phosphate absorption. Vitamin D also increases the intestinal absorption of phosphate. 3. Growth of bones. Vitamin D promotes the growth of bones by ensuring the deposition of calcium and phosphate. 4. Parathyroid activity. Vitamin D is essential for the activity of PTH, as hypercalcemia or hypocalcemia are dependent on amounts of vitamin D. 5. Teeth formation. Vitamin D helps in normal teeth formation. Deficiency of vitamin D. The main causes are insufficient exposure to sunlight, lack of dietary intake, chronic liver diseases, chronic kidney diseases, intestinal absorptive defects such as diarrhea, obstructive jaundice, partial gastrectomy, and malabsorption. Congenital absence of enzymes required for the activation of vitamin D. 1. Rickets. It is the condition of deficiency of vitamin D that occurs in growing children. It is characterized by the following clinical features. I serum Ca2+ level, slightly depressed due to increased osteoclastic activity in bones. 2. Serum Po42 level, increasingly depressed to 1 to 2 mg/dl, normal equals 2.5-4.5 mg/dl, due to PTH activity. 3. Changes in bones and teeth. Following changes occur in the bones of children due to vitamin D deficiency. Increased osteoclastic activity. Resorption of calcium from bones. Bones become fragile. Newly laid bone is uncalcified. Various skeletal deformities such as bow legs, kyphosis, lordosis, scoliosis, pigeon chest and craniotabes. The appearance of Harrison's sulcus and potbelly. Swelling of costochondral junctions as a rickety rosary. Delayed dentition with defective enamel prone to dental caries. Figure 21.6 Features of rickets. Source: emedicine.medscape.com. 2. Osteomalacia, it is also known as adult rickets. It is commonly found in the low socioeconomic group, particularly in females who have undergone repeated pregnancies and lactation. Bones are soft, fragile, and easy to get fractured. Looser's zone is the characteristic radiographic feature. Muscular weakness causing difficulty in climbing stairs and getting out of the chair. Carpopedal spasm and facial twitching may manifest tetany. Spontaneous fractures and collapse of vertebrae are common. Hypervitaminosis D or vitamin D intoxication, it is a rare but potentially serious condition. It occurs due to the intake of too much vitamin D, usually as high-dose vitamin D supplements. Excess of vitamin D can cause abnormally high levels of calcium in the blood. This can affect bones, tissues and other organs. The main clinical symptoms of vitamin D intoxication are confusion, apathy, recurrent vomiting, abdominal pain, polyuria, polydipsia and dehydration. Chances of urinary stone formation are also increased. 21.5 Vitamin E. It is a fat-soluble vitamin also known as tocopherol, antioxidant factor or anti-sterility factor. Various forms of vitamin E are available such as delta, etc. Tocopherol is the most active form. These are all methyl derivatives of tocol. The molecular structure represents a chromanol ring with a side chain located at the carbon number 2. Sources of vitamin E: animal sources, milk, egg yolk, liver, cheese, butter, etc. Plant sources, wheat germ oil, cottonseed oil, peanut oil, etc. It is resistant to heat and acids but destroyed by cooking and freezing temperatures. Figure 21.7 Structure of vitamin E, various forms of tocopherol. Absorption, transport, storage, and excretion of vitamin E. The mechanism of absorption and transport of vitamin E is the same as that of vitamin D and other fat-soluble vitamins. About 40% of dietary vitamin E is absorbed by the enterocytes. Absorption is enhanced by bile salts. The absorbed vitamin E first appears in lymph and then transported to the blood circulation as a part of chylomicrons. The uptake of vitamin E from chylomicron remnants by the liver is conducted with the help of tocopherol transport protein. It is then exported in association with various lipoproteins such as VLDL, IDL, and LDL. Storage of vitamin E occurs in adipose tissue, muscle, pituitary and adrenal glands. The excretion of vitamin E occurs through two main routes. The major route of excretion is through bile, which is then excreted in feces. The second route is in the urine after conjugation with glucuronic acid and shortening of the chain to more water-soluble. Recommended dietary allowance, RDA, of vitamin E. Children, 5 to 10 IU. Adults, 15 to 20 IU. Pregnant and lactating women, 20 to 30 IU. Note, IU, International Unit, of vitamin E equals 1 mg. Functions of vitamin E. 1. Antioxidant, it prevents the formation of peroxides. Protects the vitamin A and polyunsaturated fatty acids from destruction. 2. DNA synthesis, it controls the synthesis of DNA. 3. Muscles, it is essential for the normal function of muscles. 4. RBCs, it looks after erythrocytes and prevents their hemolysis. 5. Activator, it acts as a coenzyme for various enzyme systems, example cytochrome C reductase. 6. Reproduction, it is also necessary for normal reproduction according to certain experimental studies on animals. Deficiency of vitamin E, the deficiency of vitamin E occurs rarely. Its deficiency usually occurs secondary to malabsorption syndrome, biliary obstruction, cystic fibrosis, and liver disorders. The main clinical symptoms of vitamin E deficiency include hemolysis, edema, muscular dystrophy, reproduction dysfunction, abortion, and liver necrosis. Many neurological symptoms are also seen, like decreased reflexes, abnormal gait, peripheral neuropathy, ophthalmoplegia and vibratory sensation. End of Part 1 of 4, of Chapter 21. Thank you.